Hello, and welcome to Ethics on Call, the podcast of the Center for Theology and Ethics in Catholic Health. I'm Tom Bushlack.
And I'm Dan Daly.
And today we're going to take up for the second time the newly promulgated 7th edition of the ERDs, the Ethical and Religious Directives for Catholic Healthcare Services. Quick reminder, those were newly promulgated by the U.S. Conference of Catholic Bishops at their November plenary session just a few months ago. So that first episode we took a general look at the significance of some of the larger developments in that text, and also some of the developments that we called kind of under the radar. We're going to switch things up, get some other people's perspectives this time. So Dan, can you walk us through how we're structuring this episode and who our guests are going to be?
Sure, Tom. And, we have an all-star group of interviewees to share with the audience this month. The first is Father Charlie Bouchard, a Dominican friar who is currently a senior fellow and adjunct professor in ethics at the Aquinas Institute of Theology in St. Louis. And he had many previous, positions before his current position, where he notably was the senior director of ethics and sponsorship at CHA. We also have the second interview is both Dr. Amy Hertweck-Warner and Dr. Jenna Speckart. Dr. Hertweck-Warner is the director of ethics at Mercy St. Louis, and she practiced clinically as an OB-GYN for 15 years before transitioning full-time into ethics. And Dr. Speckart is the vice president of mission and ethics operations at Mercy. And finally, we have Dr. Anitha Rayani, a palliative care physician at SSM Health at St. Joseph's Hospital, where she also serves on the ethics committee. So again, really an incredible group of people to reflect on the ERDs. These are people who have helped to shape them over the course of years, whether it's consulting with the USCCB or have been implementing them in different spaces, whether it's ethics and mission, or in the case of Dr. Riani, clinically in her work as a palliative care physician. So yeah, I'm excited to share these interviews with the audience.
Yeah, we've got a nice diversity of opinions from the kind of high level ministry level down to the in the field, as it were, in the hospital local level. So we're going to get a really great perspective, including a good historical perspective that Father Charlie Bouchard starts us out with. So without further ado, and less listening to Dan and I, we're going to jump right into our interview with Father Charlie Bouchard. Well, welcome, Father Charlie Bouchard. Welcome to Ethics on Call. Thank you for being here with us and taking time out of your day to join us and talk about your experience. Really grateful to have you here.
Thank you.
Yeah. Welcome, Father Charlie. And we invited you on to talk about the recent history of the ERDs. Can you narrate that history for our listeners? And I think the reason we're interested in it is that it provides some context for this new 7th edition.
Sure, I'd be happy to do that. I think one of the things that's apparent if you look at the history of the ERDs is that in many ways it's a living document. It has its remote origins as far back as the 16th century, in which there was very little medical treatment to go around, but there were a few ethical questions. And then that became more complicated as medical technology developed and evolved, especially in the 20th century. And the ERDs have evolved both in content and in authority, as we'll see. That at one point they were kind of unofficial hospital directives, then they became something that was put together by the Catholic Health Association, and most recently they have been issued by the U.S. bishops. And even though the content and the questions dealt with have changed over time, it's important to note that the principles have not. The ethical principles that we use are pretty much the same as they were back in 1921 or even before that, when the very first attempt at some kind of ethical directives was undertaken. And the same principles have been applied even as a lot of new issues have emerged. In that 1921 document, I don't even know if you could call it a document, it was more kind of an operating room uh, poster, I think. It dealt mainly with surgery because that was the highest tech thing that we had in healthcare at that time. As time went on, it wasn't very many years before we had other things. And so when the first official version of the ERDs came out in 1956, which was written by the Catholic Health Association, they had already begun to deal with some other issues more than just the surgical suite. So that was kind of the first step in expanding the scope of these directives. By 1971, because we were looking for some uniformity across dioceses in the country, the USCCB began to take over authority for the ethical and religious directives in close collaboration with the Catholic Health Association, because they didn't want to end up in a situation of geographical morality, as some people described it, in which one bishop allowed something and another one didn't. And even though the bishop still has ultimate control over the interpretation of the ERDs, they are much more universal and standardized across the many dioceses in the US. By 1994, the third edition of the ERDs assumed its current format that had an introduction. And this was, each section had an introduction, and this was important because they were no longer just rules that had to be obeyed, but they made an effort to try to explain why and where these rules came from. So these theological introductions became, in my mind, just as important as the specific directives in helping physicians and others understand, well, why does the church say this? It's not just do this or don't do that, but let's unpack this and talk about the scriptural and the theological basis for this. The 1994 edition also introduced social concerns, questions like allocation of healthcare resources and access to healthcare resources. So it began to move away from narrowly individual clinical issues, which had been largely the focus of the ERDs up until that time, to say, all right, what about Catholic healthcare as an influence in society? What role do we have as a corporate being to shape public policy and to contribute, especially through advocacy, to the development of public policy? The 94 edition also included an appendix on cooperation. This had not been an issue prior to that time, to a great extent, because Catholic healthcare operated pretty much in its own bubble. Most hospitals were independent, and they did not interact with a lot with other healthcare around them. They kind of did their thing, and they did it well. But then, as circumstances changed, both economic circumstances and specialization in healthcare, which required different kinds of healthcare systems to collaborate, because not every hospital or every system could offer every single expensive high-tech treatment that was out there. So they had to start to collaborate more, and then that raised questions about when we get into the realm of illicit cooperation. In other words, are we partnering someone, for example, in providing a service line that also leads us into perhaps illicit cooperation with other things that partner is doing that we can't be involved in? So that appendix appeared in 1994. And then in the fourth edition in 2001, the appendix disappeared, but the content of those principles on cooperation were built right into the text of the ERDs themselves. That fourth edition in 2001 was really a significant overhaul, and it also included more detailed directives on sterilization, vasectomies and tubal ligations, and other areas which had not received as much attention prior to that. The fifth edition in 2009 was kind of a watershed because it was dealing with another new issue. The question, well, actually, with two of them, with what was called at the time patients who were in a persistent vegetative state who were not going to recover, and then the question of artificial hydration and nutrition, which was an issue in itself, but it was a more complicated issue when it came to the question of non-competent patients who couldn't make their own decisions. And so the fifth edition had a section on that, and I might add that this was right around the time of the Terry Schiavo case, which brought this question of persistent vegetative state and artificial hydration into large, widespread public awareness. And, even though we try to keep healthcare at the bedside, unfortunately, this got all the way into federal courts, which it never should. But it was just one of those questions that we were trying to sort through at the time. And then in that fifth edition, there was the famous or perhaps infamous Directive number 58, which tried to indicate when it was obligatory, morally obligatory, to use artificial hydration and nutrition, or does our obligation to feed a patient ever end, even if they have permanently lost consciousness? And number 58 was fairly clear about it, but it put the two words "in principle" before their statement. So that gave a little bit of leeway, but it also muddied the waters a little.
Mm.
And I have to say that even after many years, I'm still surprised at how many Catholics are concerned about whether they are able to forego a treatment and not commit suicide. And so we have not totally tackled this problem yet. The sixth edition appeared in 2018, and it was again largely concerned with the question of institutional partnerships because the trend toward mergers and acquisitions and different kinds of collaborative relationships had continued to grow. And some of the material in this edition number 6 was driven by the same questions about specialized medicine and efficiency, which raised the issue earlier. But this version also drew in some comments and input that came from the 2014 document from the Congregation for the Doctrine of the Faith, some principles on cooperation. And then there was also a separate document on cooperation, which was produced about that same time. And these things, I said, it wasn't as big an issue in the past, even though we always served patients who were not Catholic. We always had physicians and nurses who were not Catholic. But this new level of institutional collaboration raised these more complex questions of when illicit cooperation might take place. And then finally, in 2025, most recently, we received the seventh edition of the ERDs. And this had a number of things in it, including a more detailed treatment of abortion, as well as more clarity on in vitro fertilization questions that had been raised from various kinds of reproductive technology. It specifically mentioned and prohibited cryopreservation of embryos or eggs. And it also explicitly mentioned the importance of palliative care. And I think that this was probably in result to concerns about what is commonly referred to as overtreatment, but really is more accurately referred to as non-beneficial treatment. Patients or families who say, well, we want everything possible done, especially if somebody else is paying for it. And sometimes everything is not in the patient's best interest. So I think that their invocation of palliative treatment, and I think they mention hospice in there as well, are ways of trying to provide another path for patients rather than do everything possible. It's really a statement about our supernatural destiny, about being created for our life with God, so that we don't have an obligation to keep using new medical technology, however rare the possibility of benefit it might have. It also continued to stress social responsibility, not just for clinical events, but this institutional influence that the Catholic healthcare can have. And it also changed the terminology of persistent vegetative state to unresponsive wakefulness syndrome, because vegetative clearly has rather negative connotations when we apply it to a human person in any sense. And so this was again an attempt to recognize the reality of this, but to find a more accurate and respectful term to describe it. But the most important part of version or edition 7, which is probably the reason that it was really revised, that was the main motivation, was to treat or to discuss gender dysphoria and incontinence. And it's a difficult thing to deal with because we do not have total scientific or medical clarity yet, even on what causes gender incongruence or gender dysphoria. But as it has in the past, as they have in the past, the ethical and religious directors evolved to deal with new issues. There were many new issues over the many years that they had been revised before. This again, even though you could argue that transgender persons have always existed, there was really not effective treatment for them until very recently. So we had to take on that issue and ask ourselves, okay, what would be, if we recognize this as a clinical condition, then what might appropriate treatment be for it? And these directives, edition 7, came up with a pretty conservative response to that, and basically feels that these directives make it clear that they do not see that attempts to separate gender and sex are ever morally acceptable. I don't think we've heard the end of this yet. I think we have other things to learn as we gain more experience with this.
That was incredible. Thank you.
That's great, Chuck.
Yeah. I guess we can just end here. No, I'm kidding. Because what I appreciate the historical context, and I believe there is an article that Ron Hamill wrote that covers some of this ground, and we will link to that in the show notes for folks listening. I think you also mentioned a couple of things that are, sort of like minor updates and revisions that we actually didn't cover in our previous episode. So I appreciate that, because there are, we really can't do it all. And I think, like you said, as a living document, some of these may come up again in different contexts, and some may settle rather quickly. But I think getting to the final piece that you sort of landed on, I know that you were involved with at least some of the early moments of soliciting feedback and giving input. That again, Nate talked about that on our previous podcast, so people are familiar with that process. But can you share a little bit about what you were involved with? And at the time, you were working for CHA, just to be clear, though you are not currently employed with the Catholic Health Association. But yeah, what was your involvement with that? What were some of your takeaways from that?
I was involved in a dialogue between CHA and the U.S. Bishops' Committee on Doctrine for, I don't know, I think over 2 years. And we probably had 6 or 8 meetings. And we were really trying to we were trying to help the bishops formulate a position on this. We came at it from obviously the clinical perspective. We invited some trans persons and parents of trans children to meet with the bishops, which they did. and they presented, their perspective on this, because we really wanted the bishops to understand the experience, not just of the patients themselves, but also of the families, because we don't always think about this as being a trauma for families, which it often can be. What am I going to do with this child who's not behaving like a normal boy or girl? How do we deal with this as parents? And the dialogue that we had, the eventual result of it, CHA had a lot of input into it. The eventual result of it was the doctrinal note that the bishops issued in, I don't remember what year that was, 2023 maybe?
Yeah.
Yeah, 2023. And then eventually the substance of their position in that document was brought into the ERDs. So we had a lot of great conversations, but it was tough because of the clinical uncertainty, and also because many of the bishops, the way that they were introduced to the issue of transgender experience was through their schools, with questions about students who were experiencing gender dysphoria. Well, those are two different issues. There are common questions for both of them, but the clinical issues are different from the social issues involved in a child who's transitioning in a school setting. So those are still things that we need to work on.
Yeah.
Charlie, it makes me think, your working with them and bringing in families and people who are experiencing gender dysphoria. We have Directive 29, which talks about, really kind of understanding the suffering, understanding that this is a vulnerable group. These people are not to be ostracized. They're not to be demonized. They're to be loved. They fully image God, no matter what they're experiencing at the moment. And so I think, it's those kind of experiences. It's in meeting the people who experience gender dysphoria that you really do come to see their vulnerability, their suffering, and that is now codified in the directives for the first time, naming them as that vulnerable group that they are. And because so much of the discourse in the media today is so vitriolic regarding, they've been held up as, they've been demonized politically and socially. They've been used as punching bags, so to speak. And the bishops are really pushing back against this here. And I think it's through the good work that you in CHA did on this, I think that helped to move that forward. So yeah, well done.
Yeah, that's very true. And one thing we said repeatedly to our clinicians and our executives, as well as to the bishops, is that we have to stick with the science and don't get trapped by the ideological questions or the politics of it. Because as you said, Dan, this has become a political cudgel in a lot of cases, and these patients get caught in the middle of this. So we need to stick with the science and treat them with respect and compassion, just like we treat every other patient. And sometimes I think the term gender affirming care has been hijacked to just mean transition services, like surgery or hormones. I think for us as Catholic hospitals, there's more than that. It's got to start with how they're treated at the door. Do we affirm them as persons? Do we listen to them? And do we help to hear their perspective?
I think that's a really important point, Father Charlie, because it isn't just about, one particular kind of surgery or transition or even hormone treatment. When I was working in healthcare, I know we went through a process where ethics was involved in consulting on working with our patient access coordinator. So those are the people that are at the front desk of a hospital or clinic where you go to check in. And, there are a series of protocol type questions that have to be asked that we need from every patient. And questions like, and we had to rephrase some of them based on what they had been historically, given a new understanding of who our patients were and our desire and commitment to treat them with dignity. So questions like, how do what pronouns and what name do you prefer to be called?
Right.
And I don't, and we had to deal with this, like, it doesn't matter what your personal opinion is on this issue. This is what we are doing as an organization to affirm their identity. Some people loved it, some people not so much, right? Um, but even questions, and I can't remember how we landed in the language, but the question of what sex were you assigned at birth, or some form of that question, and it's very tricky to ask in a dignified way, but it's also very essential because from a medical perspective, if someone walks in presenting as male, and as a physician, I assume that they are male and have all the male sexual organs, um, but they are not, I may end up doing treatments that could harm and or even kill that person if I don't know that. And so, I think this is good to get into the nuance of it, because, those kinds of gender affirmations and in some cases even medical necessity were no-brainers. We were not sitting there saying, "Oh, we can't do this because of the ERDs." Like, in fact, that didn't even come up. It was like the ERDs are clear about what kinds of things we don't do, but we still treat the fullness of the person when they walk in the door.
Right.
So that's kind of sharing from my experience. I wonder if you have any other thoughts, or you can respond to that, but any other thoughts on the current state of medical knowledge? And I just want to put a caveat that we have 3 doctors here, but none of us are MDs. We're all PhDs. As my kids would say, "Yeah, you're not a real doctor, Dad." Uh, but
Yeah.
your thoughts
Sorry.
on that, like, because that's it as a principle of our work and really all bioethics. Dan and I and other bioethicists talk all the time. Like, if we don't understand the basic science involved, at least to a competent level, maybe not in the way that a full MD or medical researcher would, but um, we're not even, I would say, equipped or have the responsibility to make a moral judgment about that until we understand the moral object, to use the traditional language. So that was a long one, but I'll stop and let you answer.
Yeah, I think, I think well, I don't know if we've got a consensus, but I think science is moving towards some kind of consensus about the origin of this. My own view is that it's largely the result of prenatal hormonal influences.
Mm,
I think sexual identity generally, and even transgender, are established pretty much before birth. And I worked a lot with the World Professional Association for Transgender Health, and they've written the most credible medical treatment standards. I think they would probably agree. Now we don't have this all figured out yet,
sure.
so this is definitely not something that's a choice. We went through this with homosexuality many years ago. Is this a chosen lifestyle, or is this something that you've got and you have to learn to live with? So I just think we need to be very attentive to that and to, listen to what we're learning and how we begin to understand this complicated relationship between the mind and the brain.
Mm,
Yeah.
yeah.
Well put, Charlie. Thank you for that. It makes me think in terms of, we've had this document now for 31 years, as you noted. And the document went through a substantial change in 71, as you noted.
Mm.
And then there was a generation that it served its purpose. It was revised in the mid 90s. And now we've gone a generation plus between that substantial revision in 94, which you noted was revolutionary at the time. It brought in much deeper theological and ethical thinking. It rounded out the church's teaching on the healthcare as a ministry. Um, it makes me think, I mean, there's been some conversation. I know your colleague Ron Hamill, who we mentioned earlier, has suggested maybe it's time to rethink the architecture again of this document. And we have other documents like the Canadian uh, documents that's put out by the Canadian Health Alliance. I'm curious, do you have any perspectives on that? Having gone through this history and known this history for so long, do you have a position on what you think the next iteration of the ERD should be? Should it be, we put in some new directives for new technology, or do we reimagine the document altogether?
Well, one of the challenges of healthcare generally is that we usually begin with procedures. How can we treat this? And I think we can see in the development of these directives that they've kind of moved away from just making judgments on specific treatments to asking bigger questions about the human person. Like with the transgender issue, that's really fundamentally the question. What does it mean to be a human person? And is this knowledge that we have about transgender experience, does that fundamentally alter our understanding of the person or not? And I don't think we've got an answer to that yet. The other thing I would say is that in the future, if there were to be a major change here, and others have said this before me, but it probably needs to involve more about how we shape a Catholic culture in our healthcare facilities. Because yes, the laicity of certain procedures is important, but ultimately, if we don't have a culture that supports our identity and the directives, it's not going to get us very far. And I think we've been kind of inching toward that over the years. But if there were to be any big change, that might be it. More emphasis on that.
Mm.
Yeah. So on the organizational side, as
Right.
opposed to the clinical side. Yeah.
Mhm. Yeah. Becomes almost a formation question as much as an ethical question.
That's right.
Yeah, that's very
Exactly. In
interesting.
fact, I'm working on a project right now about formation for ministerial juridic persons. And initially, they didn't even mention formation in the documents for the first PJP that was created. They hadn't even thought that far yet. Well,
Mm.
now we can see that's going to be essential for the future.
Yeah, yeah, absolutely. Hmm. Any other questions or anything maybe we didn't ask you that you think is important or relevant that you would want to bring up?
I guess only one thing, which we talked about a few minutes ago. When I got into this stuff, when anybody ever mentioned transgender, I immediately thought about genital surgery.
Mhm.
And I think a lot of people probably do. And I think I know I've had to learn to see trans people as persons. A lot of trans people don't even have genital surgery. I'd say probably less than half, maybe, and some opt for no surgery at all. They do hormone therapy or something else. So again, this is varied according to particular patient circumstances, and we need to keep the focus on them as persons and not just as objects of scientific manipulation.
That's an excellent point to end on. So just thank you again, Father Charlie, for being here with us and taking time and really excellent both historical and medical and ethical insight and perspective. So really appreciate you joining us. And I know our listeners will gain a lot from hearing your perspective as well. So thank you.
Thanks, Father Charlie.
It's great to be with you both.
Well, Tom, that was great historical perspective from Father Charlie. And, it's important for us to know the historical context of the document, that it didn't just come from nowhere, that there's a long history behind it. And I really interesting reflections that we'll talk maybe a little bit about at the end on caring for persons experiencing gender dysphoria. So
Mhm.
hopefully that helps to spark some thinking in the listening audience. But now we'll turn to our next interview, which is with Dr. Hertweck-Warner and Dr. Speckart. So, Dr. Speckart and Dr. Hertweck-Warner, welcome to Ethics on Call. Thank you for joining us.
Thank you. Welcome. Thanks for having us.
Of course. So we wanted to start with kind of a generic question, and then we'll get maybe a little more specific. But from your experience sitting at both a ministry and a hospital level ethics roles and mission roles, what has the response been from the healthcare professionals, providers, administrators outside of ethics and mission that you work with?
Something I found really fascinating about this most recent edition is as I spent time and as our colleagues spent time really reflecting on what was to come and then what was released. Um, Looking at it and actually saying, okay, what has substantially changed with this? Has kind of positioned me in the seat that we're in, and Amy in the seat that she's in, and all of our ethicists across Mercy, to say, okay, what type of response is needed in this space? Because certainly, when you ask this question about, what have other professionals said, so many of our different professionals outside of ethics take a look at this document and they say, oh gosh, it looks like a ton has changed about this, right? There are new directives in new places. There are a lot of new words and ways of explaining things. And then they turn to us and they say, help us to understand what really has changed. And that's where I take a lot of comfort in looking at this document and having studied it to say, substantially, not a lot has changed in it. There's so much that has stayed so faithful to our beautiful tradition and how we care for people, especially with the topic that we're talking specifically about today, that beginning of life and that end of life, that we're able to give a lot of confidence to those outside of, the work that we do in mission and ethics to say, look, what you are doing, the way you are caring for people, keep doing that, keep maintaining that, and keep looking to that. There's been some who were really attuned to the changes and others who are not, right? Some who were the day that they came out were sending us emails saying, "Hey, want to let you know I have a lot of questions about this." But most others, outside of maybe our notification, haven't really said a whole lot about it. And so that variation that has been there is part of the ways that we thought about what our response needs to be. And certainly from the perspective that I sit in is saying, hey, we can still be really confident that this document is a beautiful guiding force for us in so many ways. Amy, what would you add from your perspective?
Yes, Jenna, I would echo that. But of course, in the clinical spaces, people are pretty practical. What does this mean for my practice? What does this mean for the day-to-day care that we provide patients? And it was very nice to be able to say, dignity is still right at the focus and the heart of what we do for each and every patient, and that doesn't change, and that hasn't changed. The way we approach sterilizing procedures is consistent. It's consistent from this edition to the new edition, even though the wording and the directives are different. The way we think about the patients who present to us hasn't changed. So I would say that there have been a lot of, on my end, more practical questions. What does this mean for the way we practice in Catholic healthcare? And I would say that I echo you in that while the directives look quite different and a lot of the wording has changed, the way we approach caring for patients is still substantially the same.
So Amy, you're getting to the real practical aspect here, which is great, and it makes me think. It sounds like you probably haven't made significant policy changes based on the seventh edition. I mean, as we're recording this, it's not even 2 months. Well, it's 2 months old today, I suppose. So you haven't had a lot of time, right, to revise policy. Do you foresee that as you read the document? Did you think, oh, we've got to change policies or practices, or did you think the policies that we have are really are good vis-a-vis this new edition?
I would say that, in terms of our care for patients who identify as transgender, it is not changed. Our practice within Mercy has been essentially what the document supports currently. And our focus has always been on how do we ensure that these patients feel very welcome in our space, that they are not in any way prevented from accessing broad ranges of healthcare services that they need, that they feel that they have a sense of belonging and inclusion when they're in our space. So I wouldn't say that we necessarily have a policy that surrounds that, but the way we approach patient care, I think just, again, it's always wonderful to have that call out that every person that enters our door is a being of incomparable worth, and we want to ensure that they feel that way. To me, thinking through a little bit what needs to change in terms of our policy really is more around the way the directives now highlight pregnant women as being a marginalized group.
Mm.
Reading that in Directive 3, I have to say it was a moment of reckoning for me to think about, pregnant women as a group that need social protections in the same way that a refugee or a incurable disease or, a chemical dependency needs protection because they're identified as being that vulnerable. Directive 44, the directive to provide care for women who are pregnant and postpartum, and the new addition about accompaniment during miscarriage. That wasn't something I think that was probably ever a highlight. 44 was certainly overshadowed by 45, which came right after it. But it's a real call out. It's a real call out to say, despite the data that we've been seeing for a long time, that we have, doubled, sometimes even 10 times the rate of maternal mortality of other developed countries. We can do better. The way in which we approach care for pregnant women needs to be reconsidered. Yes.
And when our group of ethicists at Mercy sat down and initially reviewed the new edition of the directives, our immediate reaction was not, oh gosh, this is really going to change X, Y, and Z policy. In fact, as I kind of said with the reaction overall, this because so much is substantially the same, it's going to be reflective in our policies in a lot of the same ways. One thing that I think should be maybe even called out in even more elaborate ways and is reflective of, I think, a celebration that we have in this new edition of the ERDs is, especially as I looked at Part 5 and we thought about Part 5 is how much we've really emphasized and even doubled down on how care at the end of life is so holistically important, right? That it wasn't even necessarily just talking about VSED as just the specific of that incidence, but when we look at directives, for instance, 61 or Directive 62, there was so much that said, okay, this is a whole human person, physically, psychologically, socially. The emphasis on community at end of life was so refreshing to see. And if anything, I think that may also give us some space to be able to say, hey, we really need to make sure that we're not just being focused only on the specific interventions, but gosh, how have we brought people around the patient? Have we been as focused on that emphasis on palliative care that has always been a part of our tradition, but that is called out in such specific ways in the new ERDs as they've written out in Part 5. Really could probably call us to an even deepening in our policies and practices of making sure that we are staying as faithful to that as we have always said we are. So in one way, that's a really refreshing spot to be in, that we didn't see a revision that just went back to say, gosh, X, Y, and Z intervention is or isn't allowed. Instead, it was about, remember, the purpose is to sit back and look at the whole of the patient. And are we protecting the whole of what life and dignity means, and the way people experiencing that human flourishing all the way up to the point of death? And then through and past that grieving that we experience as a community, all of that is a part of this, which is a really refreshing thing to see. So on a positive light, I would certainly say some of those revisions may be, hey, let's make sure that we are being as faithful to this aspect of wholeness as we have always been in our policies.
Listening to both of you reflect on this is kind of helpfully reminding me that, sometimes maybe and I would include myself before I actually worked in healthcare, or people kind of looking at this from the outside or the general public. It can look like, like the ERDs is like a list of do's and don'ts. But what I love about the comments that you've made is there are certain ERDs that will focus on specific things that, should or should not be done or are not in line with the tradition. But overall, that's all in this context of how do we provide holistic care. So whether we're talking about care of persons experiencing gender dysphoria, or women, or pregnant women, or people at the end of their life, those specific sort of practices are embedded within that broader communal context and interpreted in that way. And I think that's important for people to understand, maybe who do work in healthcare or who don't, and just like, have those kind of outside perspective on it. Um, I don't know if that sparks any thoughts. I guess another, maybe a more specific question around that is almost going back to the first question about what's the response been. Are there any specific things that you've heard from people that, like maybe even more than once, like recurring themes that you find yourself sort of correcting? Like, oh, I know it might sound this way, but here's how we've always dealt with this. And these new revised ERDs are helping us to do that with more clarity.
And some of the ways it might have been the collision of the changes with the political atmosphere that has brought up maybe the most consistent questions that we've had, right? So, thinking about some of the abortion laws and how that lives within the space of and time of also the changes that come to the ERDs. And while they're distinct timelines, so many of the questions actually end up reflecting around that space. And I know Amy's got lots of examples from, especially our OBs around, gosh, were these changes in light of the fact that law changed, or how did these two play? And so I think a lot of the curiosities really aren't just the ERDs alone, but the ERDs within a political climate, within certain laws and changes that have been made that cause people to maybe connect dots that shouldn't necessarily exist in the same way, or cause people to go back to those same, oh, I bet we changed the ERDs because of the change in law. And that's a lot of misconception that we try to help correct. So, Amy, I know you've got probably really specific examples that you're, working through our OBs with.
Yes, I'd say, any attention to Directive 45 and the current political climate leaves people asking questions. Was this directive changed because the laws have been changing? And, the guidance that we've received is that essentially, no, this was to ensure that the teaching informed the directive more directly, and that it wasn't intended to change the way we approach care for women. And, it's always a discussion for folks to recognize the legal implications versus the moral implications when we approach care at the beginning of life for women. And how do we balance the idea that we have two patients always at the center of our care, and how we're trying to understand medical conditions and care, recognizing that we care for pregnancies in crisis every day, and we understand that there may be times in which we aren't going to have the hoped for outcome where both mom and baby survive and flourish. But the really essentially our approach maybe now is even more supported by the legal environment. Well, it is more supported by the legal environment than it was previously, but the care we actually provide women, it's essentially the same between, the directive before and the directive after. So although the wording changed, the way we approach caring for women in crisis has not changed.
Yeah, I think that's a good point. And, Tom and I made that point in the previous podcast. The change of language was an improvement of the language. So it clarified the language. Gender, to your point, it tied it more directly to the tradition, specifically Evangelium Vitae, so the high-level document where John Paul II discussed abortion, among other different issues in the consistent ethic of life. Um, but yeah, it's a clarification that there should be no real change of the practice in Catholic facilities, because to your point, we've always said there are two patients here, and they're not in conflict. We're not pitting them against each other. We're on the side of both of them. We're not prioritizing one over the other. They're both of equal value, and I think um, the revised language helps us to continue to do that, right, with a little bit more clarity maybe than existed before.
And it's a wonderful opportunity. I think, from within the world of medical ethics, we get very focused on outcomes and we get very focused on what we need to do to achieve outcomes. And so taking that opportunity to slow down and bring back in the notion that we're looking at outcomes for both patients. So what does that really mean in this situation? And how do we think about our obligations to each of them when facing, a pregnancy in crisis?
We've covered a lot. Is there anything that we didn't ask about that you think is relevant from your experience, um, or other issues that you think, or wisdom or insights that you've gathered from this experience that you'd want to share with our listeners?
I'm very hopeful that we continue this conversation about what it means to include pregnant women as a marginalized group. Um, you know, Pregnancy is essential to our existence, and it should be at the center of our society as a social celebration. And the idea that we have to recognize that we're not doing very well by pregnant women in the way that we currently deliver pregnancy care. I think it needs to be a conversation maybe in Catholic healthcare we should dive into. Other countries, we know that 40% of women who face maternal mortality do so from delivery to the 42nd day postpartum. Most women in the United States have not seen a provider during that time. What do we need to do differently? How do we approach care for women from a more holistic standpoint? What are the necessary conditions that allow for flourishing early in pregnancy and postpartum so that, like, Jenna mentioned earlier, at end of life, how do we wrap our arms around care for patients at the beginning of life in the same holistic way that we maybe, have tended to focus either on pregnancy in crisis or the things that are drivers for women to desire to terminate pregnancy? How do we think about this more globally, the social conditions, the supports necessary? What is this calling us to do in Catholic healthcare to reimagine the way that we offer a full service and spectrum of care to pregnant women?
Amy, it reminds me that Pope Francis said the very thing you just said. He said, look, it's been true that the members of the church haven't done enough to support pregnant women in their difficult situations and in their vulnerabilities. And I think this iteration of the ERDs is pushing forward that kind of line of thinking that Francis brought to us, and that I think now, the ERDs can provide a little bit more guidance and direction, that we can elevate the focus on women, pregnant women specifically, as you've rightly indicated. I think you couldn't be more right about that. It's an important point.
Yeah, and I wanted to comment too on the broader context. So I just want to say amen to what you just said, and then elevate it. But also just to clarify, like when you said at the beginning that you said you're referring to the U.S. healthcare system as a whole compared to other developed nations, not specifically to Catholic healthcare, right? Where in this
Correct.
case, Catholic healthcare is participating in that broader system in particular ways. And I think what this ERD and what you're saying and reflecting on is calling us to is to say, let's lead in this space, given the current context of challenges to the vulnerable lives of women and pregnant women. Let's really lead and be prophetic in the current context, because as a culture and a society, we're not doing this well. So just to
I would love to see that.
clarification.
And I would say amen to that. We continue to see the statistics that we perform really poorly in maternal mortality against other developed countries. We sit at the bottom, and our nearest statistical neighbor, we're double their rates of mortality. We're 10 times or more the rates of mortality of the high performing nations. And for certain groups, our Black Americans, we can be 20 times the rates of mortality. It varies across state. So we know that access is a pivotal part of this. We know that the way we approach care is part of this. We know the way that we support women in the postpartum period, things like paid maternal leave. These are all conditions necessary to put pregnancy back where it belongs as a celebrated central part of our society, not somebody who needs to be protected at the margins.
I'm glad you brought in those broader social issues because I'm remembering some research I did a while recently that something like I think 40% of all births in the United States are for women who are covered under Medicaid. And again, I'm not making a political statement, but just a fact that millions of people are in the process of losing Medicaid coverage currently. And whether the political, social solution is to bring that back or to find another alternative or to do it better, that's a political question. But I think what we can note is just the extreme vulnerability that we are adding to currently is making this more challenging. And so again, it's the moment where I want Catholic healthcare to just keep bringing this up loudly and passionately in advocacy. But Jenna, it looked like you were about to say something.
Well, just a closing reflection that links so well to actually what this whole dialogue has been is actually a question I have found myself asking for all of my years of doing this work in ethics, which is how is it that we leave people? When they come for the intensity of a beginning of life experience or an end of life experience, and those mothers leave the hospital or those families leave, and they're now going to make arrangements for the funerals or whatever that celebration or grief looks like. I find myself frequently asking the question of how did we leave people in that? Did we leave people in a sense that really set them up and celebrated them, or set them up for a sense of flourishing, or set them up for being able to walk through grief in a way that didn't leave them heartbroken or bitter because of the experience that they had? And it's more than just a patient experience question. It's about did the care that we provide really allow us to get to a space of total healing, which is what is asked for us in our ministries, right? But healing is more than just that physical, as we've always said. And so, how did we leave? How did we leave that mother? Did she get to a space of full healing? And what does that look like? How do we leave that family who had a really messy end of life experience because of all of the dynamics and challenges that maybe cause an ethics case to come across our space? Yet, do we leave them in a space where they were or as whole as they could be after losing a member of their family and their community? But this is the question that I'm really hopeful, Amy, as you talk about that the ERDs continue to talk about that communal experience, that flourishing experience. It is answering that question, hopefully in a very hopeful way, that we left people better than when they came to us, that we left them more whole, more healed, which is the ultimate call that we have. And so just pulling in those different pieces of reflection, that's what I still find myself asking at the end of all of this.
Jenna, that's a beautiful framing to leave us with. And I'm sure our listeners will appreciate that too, to frame like, how are we leaving people? How when they leave us, how have we left them? What's the connection? How are they faring? And it reminds me, you're pulling it back to the essentials of the ministry. Like how did Jesus leave people? I mean, that's what we're after, is that we're witnessing to that. We won't be able to do it in the same way that Jesus did, but we're witnessing to it. We're pointing to it. And he left them well. He left them flourishing. He left them at least cared for, listened to, seen, touched. And I think, yeah, it's a really helpful framing, I think, for all of us who are involved in this work in different ways. So yeah, thank you for that.
And just maybe a last comment here, but it reminds me, we're talking a lot about revisions and updates and changing technology and social context. Part 2 on spiritual and pastoral care did not get revisions, but it is there, right? And it is a significant piece of what we're talking about here as that whole life accompaniment of care. That again, Catholic healthcare is not the only context in which chaplaincy and spiritual and pastoral care are offered. but it is certainly core and central to what we do, and should not be forgotten amidst all of these other revisions and updates, because that is certainly key to the care that we provide.
Well, great. Jenna and Amy, we cannot thank you enough for the time that you've given us and the insight that you provided.
Thank you.
Listeners. So thank you.
Absolutely. Thanks for the invitation and for allowing us to, as we said before, just get to talk about the things that we're passionate about every day anyway. So appreciate the conversation.
Thank you.
Well, Dan, we're grateful to Drs. Hertweck-Warner and Dr. Speckart for their insights. Really interesting combo of that kind of high-level ministry or system-level perspective and the local perspective. And of course, Dr. Hertweck-Warner's clinical perspective and work as an OBGYN combined with her ethics, just leading to some really interesting perspectives on how a document like this is first received and then applied and interpreted. So speaking of that kind of, embedded practicing contextual level, we're going to turn to our last interview with Dr. Anitha Rayani, who is a palliative care physician with SSM Health St. Joseph's Hospital. Well, welcome, Dr. Rayani. We're really honored to have you as a guest on the podcast. Thanks for taking time out of your busy schedule to be with us.
Thank you, Tom and Dan. Thank you. Thanks for
Yep.
having me here.
Yep, and good to see you again after many years ago on the ethics committee together. So before we get into the revised ERDs, can you explain to our audience what palliative care is, and maybe what it is not, how it's related to hospice care? Because I know that's not always well understood.
So, one thing I would say is palliative, like a definition way of discussing it would be palliative care definitely is a specialized medical care with a multidisciplinary approach, but this is for any kind of serious illnesses. It doesn't have to have a specific diagnosis. It does not have to have a specific prognosis. So that's the brief definition. It can be done in any stage of the illnesses. It doesn't have to be like, oh my God, this is a new cancer versus is it a stage 4 cancer? It doesn't matter. Is it CHF in the beginning, CHF at the end? So any stage of illness, any age, there's no age, like you have to be, generally we think of elderly age or as morbidities go. Yeah, we see young patients. So any age, any stage, any disease process, which is serious, which has life-threatening, life-limiting, is how I would describe it.
So it doesn't have to necessarily be palliative care is not always within the context of some kind of end of life context or fatal diagnosis. It can be long-term chronic illness management. I think that's a common misconception. Yeah.
Yeah, and the other thing is people have a lot of fear. Obviously, even in the medical community, even within the hospital, sometimes, I'm just saying, there's still a question of, oh, I'm going to call palliative care. Does it mean I'm at the end? Even the patient fears that because when they Google it, or even nowadays, I guess GPT it, because that's AI or whatever, it's like, oh, they see pictures of maybe someone holding your hand. That's the, I guess, number one picture that comes up is, an elderly person's hand is being held by another person. And you feel like, oh my God, this is the end. That's the picture that gives. But yeah, we definitely want to hold hands, but it's more to it because it's like a holistic approach. It's the patient and the family at the center. And then what are the other things that are going around? Is there a medical issue? Yeah, we can treat it. Is there a spiritual issue? Is there a financial? I mean, obviously, we cannot fix the finances, but how can we help them navigate it through social work, to Medicaid, whatever it is? So the whole picture of the person at the center.
Yeah. Beautiful. And then can you clarify too what is either the overlap and or distinction of between hospice and palliative care?
Yeah. So when I'm trained to be a palliative physician, definitely do we do hospice care? We do it, but it's a little bit of it. So palliative is a very broad umbrella where there is, like I said, the medical person, the nurse, the social worker, pastoral care. We're all involved in doing what we can do best and how can I align the treatment to his goals. The patient has some goals, and how can we best fit them? Sometimes discussing more and telling them honestly about options their goals might be different, right? So aligning that is important. That is palliative care. Versus when the word hospice comes in, obviously that creates a lot more fear in people. And that is something that I fight all the time, because when we talk about hospice, I would describe it's more of a change in philosophy. If the patient is thinking, I want to be comfortable at this point in my disease process with what I know, I do not want really anything more. I want to be comfortable. I want to have a quality of life. I don't want any more sticks. I don't want any more chemotherapy. I don't want to see a doctor. I don't want to see the hospital. Yeah, then we think, so what I want to understand is, just because we cannot cure, it doesn't end there. Caring continues. You know, the curing part, yeah, we did what we can. They don't want it, or the doctor says, we have nothing more. The caring continues. And that's what hospice would be. Hospice is also, the other thing would be, it is a Medicare benefit, insurance benefit that people should know that they should be able to use that, because it has so many services. It has a social work. It has a bad day coming and helping your mom or brother or husband with something. It has a music therapist who will come and do just music, just enjoy whatever you want. There's a spiritual aspect to pastoral care comes and visits you. So that's all the services that can provide. So 3 things. I would say the philosophy of comfort and quality. The second thing would be, it is an insurance benefit that's provided. Generally, they say 60 days. So that also fear causes fear. When you have the patient only 60 days or less, then you have hospice care. But we always have to talk through it. What does it mean? In an Alzheimer's patient, it could be a year. I do not know. Right? We cannot play God. I always tell them, we don't play God, you know. So we always advocate for you and do the best we can. So that's hospice.
Right. Well, Dr. Rayani, as a palliative care physician, you saw the new directives, the new ethical and religious directives, which included language in Directive 61 to 63 on palliative care. Um, I'm especially interested in your thoughts here on that new language and your thoughts on the call that the bishops make to employ, just as you note, multidisciplinary palliative care teams to address the suffering that may be physical, psychological, or spiritual. What are your reactions to these new directives?
So I reviewed them. I think the basic thing that you should go with it is, when you have a new diagnosis or a disease, the human dignity does not diminish, It's a disease, but you are still you, the person, right? So that's, I would say, I would take that from the first one, section 61, I think. And it does not reduce a person's worth, and he is still there, and we should walk with him till the end, continue to care for him, support him. I think being there for him, so that he doesn't feel lonely. Or sometimes I see patients with families around them still feeling lonely, because there's a fear, his moral goes down, and there's so much more that happens to him, right? And because he's thinking, oh, in maybe a few months, I cannot walk. I cannot go to the bathroom and clean myself. There are so many things that are happening with him. So we need to walk with him the entire way and say, we will support you at every step. I think that's dignity of life. You are not anything less than what you are. You are not 1% less than what you are. If not, I think I would say you are more, you need more. I think my patients need more. Yeah, you have cancer. Yes, I want to support you in more ways. So that's what I get from at least the first thing. And then the other part about spiritual accompaniment glorifying pain, because I hear that in patients where, I've had conversations where they say, God gave me this, I need to suffer or I need to go through this, I can, when we are talking about, goals of care discussions or code status discussions, they're like, I need to go through all this. And I always tell them, God's intention is not to make you suffer. That's not the intention. That is why we are here to discuss and address that. And sometimes just sitting with them and saying, you can make whatever choice you can at this point. And it's, they take a lot of negativity from that. God gave me this, I have to suffer. I'm like, no, God, that's not God's, He's not putting that burden on you. Let's share the burden and see what, where I can help you. Yeah, it happens.
Yeah, I mean, yeah, that's an incredible way to put it. And I think, first of all, you're an excellent theologian, Dr. Riani. I think you found your vocation in palliative medicine, but you may have another career. Because just as you note, God doesn't cause the suffering, God allows it. I mean, that's the best theological explanation that we have. God allows us to suffer and somehow pulls good out of evil. We can't see that, only God can.
And sometimes that suffering gets families together.
Yeah.
Because I have seen so many connections happen at the end because we all have the family drama. I don't know if I have family drama too. I'm not alone. So we all have it, but then sometimes that gets the family together.
Yeah.
And and that is such a positive thing for the patient that I've seen who sees their son or their, or their grandson at that time. Yeah, I said, maybe that's the positive side of it. How do you, well, and then I just want to tell you one more thing. I had a patient who so clearly wanted to be DNR, DNI, but there was a family member with in all good intentions saying, no, mom, I think mother, you have to continue. And so she had a lot of conflict, very religious, spiritual person. And she told me, why is not God helping me? And I said, God is helping you. He gave you such a clear mind, because sometimes this is not possible, where you want one thing, the family wants another thing, but there's conflict. But you have a very clear mind. You have our support. We can have a family meeting. Let's talk. That is one way of, God helping you with a clear mind. So whatever small things sometimes we have to take and put it back to them.
That's great.
Yeah. I'm just thinking, not only did God give you that clear mind or the patient, but also palliative care as a discipline and physicians, right, that think this way.
All of them in the hospital, we always want to support, right? We want to do the best.
Yeah.
Sometimes we don't know how to do the best, but we pause.
Mm-hmm.
Yep.
Yeah. So as I mentioned, we met years ago on an ethics committee. So I know you have a lot of experience. What have you seen as kind of the most helpful contributions that your perspective or a palliative care perspective can bring to the ethics committee? And of course, we think of that as a lot of those end of life conundrums that come up within ethics committees. But yeah, where have you seen that be most helpful or effective?
So one thing I've seen is when you have a good palliative care program more established, I think they can also deal with some of the ethical issues that come up. Because once you have, because if a hospital does not have palliative at all, I think we'll see more ethical issues come up, because so many times when we discuss in ethics committee, there's so much of this family dynamics,
Mm-hmm.
because one wanted this, the patient never talked with anyone. And I think as a palliative physician, I've spoken with 10 people, sometimes in the family, sometimes 4 of them are on Zoom, once in California, and some of them didn't see their mom for 2 years. Or, it happens. Life happens for all of us. So I think most of it is family. It's not like even the families want the best interests. 99.999%, I said, we all want the best for my dad, for my brother, for my husband. But then there's also emotion, because emotion is the big factor. Guilt is a big factor. There's so much guilt that comes on when you're not seeing my mom. I go to India for my dad. I don't see him, I see him a couple of times a year. I still am lucky to go in very often. But my sister is right there, right? So when something happens, I cannot say, hey, don't do this, don't do that. And that's a conflict. Or keep him on the bench till I come. That's a conflict, right? So I think trying to get everyone's perspective, and what I realized is once we sit everyone, yeah, sometimes I've had meetings for 2 hours. We had to take breaks and come back because we cannot make a decision. It's okay. The goal is not for a decision. The goal is we have to put into their mind saying, what would your mom want if she sees herself like this? So that part, I think, helps me with the ethics. I mean, I'm just saying, ethics, I'm so glad we have ethics committee to reach out and stuff, because especially it's about family dynamics, it's about feeding tubes. And most of it is, I think, I could not say lack of education, because we see it in the medical world and we think, oh, everyone should know this. I don't think so. I see a peg tube discussion every other day. For that family, that could be the first time in their life they're surprised. How the hell can a person not eat and be? I mean, that's coming to them for the first time. So I think that's where I feel it's it's all in a Venn diagram: ethics and palliative and spiritual. That's how the world should work.
Well said, especially on that final part about the interdisciplinary Venn diagram. And something I just want to highlight that you brought up towards the beginning of your answer is also the sort of systemic question, because not every hospital or every system has palliative care. And I think that is another sort of big picture piece of this, that by including more language in the ERDs, it's drawing our attention to the fact that when we think about what is distinctive about Catholic healthcare, certainly accompanying people through illness and end of life kinds of decisions and family relationships, is just core to supporting human dignity. So I think that question of how do we provide more systemic support for having that resource available is also highlighted by the new language here. Yeah.
Yeah, definitely. I think it's basically you matter should be the thing for me. You matter. I don't care what else is around you. Sometimes I fought with the not fought like had a discussion with the patient's family saying, I totally understand how you're advocating for your mom and your dad. Just like that, I'm advocating for my patient. It's just both of us advocating for the same person. And sometimes perspectives difference and experience, everything changes, and you just have to sit down and talk. I think we just have to listen.
Well said. Is there anything that we didn't ask you that you would like to say to our audience?
I just want everyone to know that don't be fearful of palliative when they come up with that term, with that hospice term, because let us help you. I think, and also there are so many studies and research is done where early palliative helps you actually live better with less guilt, less fear, because there's a team around you helping you. It's just not you and the family. Same thing with the hospice. I don't want the families to think, oh my God, I tell them all the time, I don't do hospice now. I worked almost 5 years ago as a physician there. And when it's so beautiful when they have that hospice services and they take the full benefit of it. It becomes, even the hospice team becomes like a family member. We try to do so many things with the kids and the grandkids. We make them write letters for, sometimes you know that your time is limited, but what can you do to still be present, right? So I don't want it, fear to be a factor. Open up, ask questions, read more about it, ask your primary cares about it. I think, sometimes it takes time, but it's still, I want more people to be less fearful of it, so they get the benefit of it.
Wonderful. Well, thank you so much for those words of wisdom and encouragement. And and for spending time with us. And we appreciate not just your time here, but the work that you do with your patients and the ethics committee and everything in between. So thank you.
Yeah, it's a teamwork. I think we're all part of it. With the patient at the center, and I think we need to continue. Sometimes we don't have a full palliative program. I have half a palliative program with just a nurse, but it doesn't matter. You try to do what you can do best, and and hope for the best, and yeah, things will fall in place.
Absolutely. Well, thank you so much.
Thank you, Dr. Riani.
Yep. Thank you so much for having me.
So, Tom, it is really great that we had Dr. Riani on as a palliative care physician, given the new inclusion of palliative care in these directives. So it's exciting, I think, for us to think about the ways in which this will push forward palliative care in Catholic settings. But as you look back on the 3 interviews that we did, are there any takeaways that stand out for you?
Yeah, great question. Be brief, but I think I have kind of one, like a big picture that really came out of all 4 guests' comments, and then 2 really specific points that I think are exciting to see the possibility for Catholic healthcare to lead in. So the first kind of big picture is, this concept that the ERDs are really a living document. I thought Father Charlie Bouchard and then the article from Ron Hamill that we'll put in the show notes do a really good job of showing how this evolved from a, a set of dot points on a hospital surgery room wall, to a very official document by the bishops, and each of those directives, then over time adding in both there's now a preamble and a general introduction to all of the ERDs, and then each of the 6 sections has its own introduction. And I thought that was interesting that those intros are really helping practitioners, healthcare professionals, because that's who the ERDs are written for, to kind of understand like the theological principles and the general thrust of what's happening, so that they're not just, rules or directives kind of falling out of the sky, but and then, we do that in formation and in ethics committees, help people understand that. And I thought too, again, this came out in Father Charlie's comments, but in all of them, this sort of epistemic humility that we have, like even when we have really clear directives, they still have to be applied in the very nuanced world of human life and even of medicine and science. And we've talked before about Thomas Aquinas's understanding of prudence, like you get a lot of agreement at the level of general principles, but the closer you get to real life application, the more possibility for nuance and need for judgment comes in. So I really think that back and forth between, the document and the people living it out is exemplified in all of these comments. So that's one takeaway. And then the other one is, I think there's 2 areas that really stood out for me where I think Catholic healthcare can be a leading, almost prophetic voice, dare I say, in the current practice of healthcare in the US today. The first one really came out from Dr. Hertweck-Warner's comments about women's health, and of course is reflected in renewed emphasis on women as a particular group of vulnerable people in the new ERDs. And she noted that, among first world countries, we have some of the worst maternal and maternal fetal mortality rates in general, but then of course that's even worse for folks who are vulnerable or excluded or marginalized in any other way. So I think, is there a way that Catholic healthcare could really double down on addressing those concerns and providing even better perinatal health care for women? And then the other one came out of, again, several people brought it up, Dr. Riani, about palliative care. We're probably going to see continued loud culture war discussion about physician-assisted suicide. What does it mean to die well? What does it mean to die with dignity and compassion? And, we're Catholic healthcare is sort of always known or gets media attention for what we don't do. And in this case, that's true. We are not going to do any kind of assisted suicide in Catholic healthcare facilities. But the flip side of that is that we have this depth in the tradition, both theologically and from a medical standpoint, that is, what does it mean to surround people with care and love and even potentially healing during the dying process? Palliative care, hospice can be a really big part of that. And, that's a sort of probably underdeveloped area of care. So again, I think it's an opportunity for Catholic healthcare to really lead in that area. And I think that's really exciting. So those are some quick takeaways on my end. Do you want to add your own thoughts and takeaways?
Yeah, Tom, the one that as I re-listened to these interviews, that really jumped off the screen was that all four of the interviewees focused on some kind of pastoral reality that really considered the whole person. And when we think about Father Charlie, he was talking about how, when patients who experience gender dysphoria come through our doors, how are we treating them? Are we affirming them as persons? Do we treat them as persons who are loved by God? Which is really what number 29, the new number 29, guides us to do. And I think about Dr. Hertweck-Warner and Dr. Speckart, and they've talked about 61 to 63, these new directives on palliative care and the patient relationships at the end of life. And Dr. Speckart asked us to consider, how do we leave patients? Do we leave them healed? Do we leave them well? Do we leave them flourishing? Notice there wasn't a focus there on the specific treatments or any kind of moral conflict, but really the patient as a person, not as an object. And Dr. Rayani does the same thing in what she talks about when she was discussing palliative care and hospice. How do we help patients to live better with whatever life they have left, whatever disease they may be suffering with? Real focus on the whole person and how they're faring, not just on the treatments. To get back to the point that you made about Father Charlie's history, where he talked about the poster on the wall saying, here are the things you can't do in the surgical suite, to today, looking at the whole person, right? And that's just been a real development over time, and it had to happen organically. You couldn't, in 1921, be where we are in 2026, but we've seen that development happen over time. And this iteration of the directives really amplifies that, I think, which is important. And it really, you can contrast that with other ways of thinking about medicine in the 21st century, which Edmund Pellegrino wrote about. There's different ways you can think about what the medical professional is. And there's the professional as body mechanic, right? Very objective. You're doing something, you're treating a part of the body, you're treating a disease, not really engaging with the whole person or considering the whole person. And his response to that is, as he saw that creep in throughout his own medical practice throughout the 20th century, that to be a health professional is a healer. It's to be a carer, a healer of persons. And that is precisely the perspective that we see in these interviews. And I think certainly these interviews are drawing on that perspective being amplified in these directives.
Yeah, if I can comment on that really quick. I mean, I've met a lot of incredible, inspiring, compassionate healthcare professionals in my career. One of the first that really stood out to me was a woman who was on the very first ethics committee I ever served on. And she would always say this, and it was one of those pithy sayings, but held so much punch, was she would always say, we don't treat diseases, we treat people. Right. And I mean, that gets at that body mechanic thing, that's the focus, and that comes through in these ERDs loud and clear.
Yeah, I think you're right, Tom.
Mm.
So before we close, though, I want to express our gratitude for the insight of our guests, Father Charlie Bouchard, Dr. Speckart, Dr. Hertweck-Warner, and Dr. Rayani. For Tom Bushlack, I'm Dan Daly, and this has been Ethics on Call. You can find this podcast on YouTube, Spotify, Apple, and our website, theologyandethics.org, /podcast. If you're on one of those podcast platforms, we would ask that you follow or subscribe to our page and leave a 5-star review and some feedback about the show. Would love to hear from you. We'll talk to you soon.